Hello, I'm Deanne Healey, President of the Peabody Area Chamber of Commerce, and we're here today to share with you some valuable information about keeping your loved one or yourself safe at home. 73% of respondents in an AARP survey strongly agreed with the statement, "What I'd really like to do is stay in my current residence for as long as possible." We've put together a panel of experts in the field of keeping people at home as they age who are joining us here today. We have Pam Moran, Director of BAYADA Home Health Care's North Shore office located in Danvers, Mass, and covering the coastal strip of Essex County. BAYADA is a privately owned health care agency and has been keeping people home with comfort, independence, and dignity since 1975. Offering over 38 years of expertise in their industry. Pam has been with BAYADA Home Health Care for the past 3 years, running an office on Cape Cod before moving here to bring the BAYADA way to the North Shore. Mary Crow is the Education Coordinator for the Hospice of the North Shore in Greater Boston. Over the last 7 years, she has led the organization's professional and community educational outreach, coordinating and delivering an extensive number of programs. Michelle Haggerty is the Senior Community Liaison for Elder Service Plan of the North Shore, a nonprofit based in Lynn, for the past 3.5 years, providing education to seniors and professionals about the PACE program. PACE stands for Program of All-Inclusive Care for the Elderly. It is a Medicare program for older adults and people over age 55 with disabilities. Julie Lowe, attorney at law, is the founder of the Law Office of Julie Lowe and focuses her practice on estate planning, special needs planning, and elder law. Julie is a member of numerous professional organizations dedicated to serving the needs of elders, including the National Academy of Elder Law Attorneys, Elder Council, Elder Law Answers, and is an accredited attorney with the Veterans Administration. And last but not least, Suzanne Kaplan from North Shore Elder Services is a licensed independent clinical social worker who received her graduate degree from Boston University and also did postgraduate studies in advanced clinical diagnosis, intervention, and treatment. She has spent the last 15 years at North Shore Elder Services in client services, providing clinical management and support case management staff as the Clinical Director of Client Services. These experts each play a role in keeping you safe at home and will be answering questions over the next hour to help you navigate what can be an overwhelming process. Why don't we start with the PACE program? Michelle, why don't you tell us, how does the program work and how does somebody join PACE?
The PACE program is a Medicare program funded through Medicare and Medicaid, or you could fund Medicare and privately. It was a program that started in California through the Unlock Asian community in San Francisco in the Bay Area. Back in the 70s, they were trying to find creative solutions for meeting the needs of area seniors, medically coordinating all of their needs with activities and a lot of socialization. Congress took a look at this and said this is the way healthcare should be delivered, funded the program. So it is available from the East Coast to the West Coast. There just needs to be an organization, it could be private or nonprofit, that is willing to take a service area, develop it with all the needs that a senior might have, and coordinate it through an interdisciplinary team.
So as an elder, you don't actually have to join PACE. You just have to call upon it for services.
Well, we're actually more like an HMO, so you do actually join a PACE program.
Oh, okay.
That's why we encourage them to hear about it, visit it, think about it, and is it the right fit for them?
So do they need a referral from their primary care physician?
They actually do not.
Oh.
Some of the eligibility criteria for this program, you need to be 55 years old, as you had mentioned, live within our service area, which is currently anywhere from Saugus to Gloucester, and need services. That means someone who's starting to need transportation, perhaps has a walker, needs help with shopping, perhaps preparing a meal. Those are called activities of daily living. So a person needs help, require help for 2 activities of daily living and a nursing component. It could be diabetes management, chronic disease, a disability that they've been living with. Any of those would make them eligible to investigate further in the program. One of the last of the criteria is that you need to be able to continue living in the community safely with our services. So that's to say that the PACE program is an alternative to a nursing home, but not a diversion to a nursing home.
Okay, so is your goal to keep people in their own homes?
Absolutely, as long as they're medically safe.
Okay. So, and where are the adult day health sites located?
We have adult day health sites in Gloucester on Emerson Ave, at Beverly at the Cummings Center, and 4 sites in Lynn. Those 4 sites have a different flavor of their own. Market Street is a great example of true Lynners. Then you have Buffum Street, which is very diverse, a little more quiet. School Street is an eclectic mix of area communities. And our Friend Street site tends to be our largest Latino site.
Oh, okay. And so, and what happens at, day to day at these adult health sites?
Our same staff go to each site. That would be a primary care physician, that is a geriatrician, nurse practitioners, nurses, personal care attendants, physical therapy, occupational therapy, speech therapy, as well as our activity staff and transportation coordinator and medical secretary. These folks meet every morning and again in the afternoon. They're discussing and they're coordinating all of the needs that a senior may have. Our geriatrician only cares for a maximum of 150 seniors at one time. My family practice doctor sees up to 1,000 people.
Really?
Our doctors will make house calls. They oversee the care when our participant is at the hospital. They also will see them at short-term rehab, or if they need to and choose to go into long-term rehab at some point, a long-term placement, we would continue to see them as long as they stay within our contracted facilities.
So I'm intrigued. You mentioned about your doctors making house calls, which is almost unheard of these days.
It is.
So if I was an elder person looking to use your services, and would I need to change doctors in order to?
You absolutely would. And
Okay.
that's probably the hardest selling factor for a senior. They've made a connection with their doctor in the community, and oftentimes it's really might be even the nurse practitioner that they see more often than the doctor. The benefit of this is coordination of care. I could give you a quick example. A daughter called me last summer and her mom had gone into the hospital. At the hospital, a medication was introduced that was sent to the rehab that she went to. When she came home, she ran out of the medication, called the doctor. It took an awful lot of effort between the doctor and the pharmacy to know about this medication and be able to provide it. And unfortunately, the person ended up back in the hospital. See, the daughter, that prescription was prescribed at the hospital. Her primary care physician in the community didn't know about it. With PACE, that doesn't happen because we're very aware of what the medications are. We supply all of the medications to our participants, whether it's pills, bottles, medication box, med box, or med on time. We either deliver it to them or we give it to them at the site when they come in.
So who typically would be the one, do you see most often making the call? Is it the elder themselves or is it a caregiver?
It often depends, but it's most likely a caregiver at crisis mode. And that's the hard part. I mean, a program like this takes time
Right.
to process. We have to get the approval of Medicaid for someone to belong to this program. So there's usually a 30 to 60 day window of opportunity to get all these documents and authorizations in place, depending on how someone's paperwork is, or if they already have Mass Health, or if they know, they may have to maybe see an elder law attorney prior to making this step.
Okay. So if you had to give somebody a recommendation of when this should start to be on their horizon before they actually reach true crisis, what would you recommend? What are some of the key signs to be on the lookout for?
Yes. Once we start adding some apparatuses, as I like to call them, whether it's a cane, a walker, once you start going to the doctors on a frequent basis, if you're having coumadin levels checked, and you're having trouble navigate who's going to take me to that appointment, which daughter can leave work, or who's going to grab that medication for me after work, or help me with navigating these things. To keep your independence, a program like this allows our team to support the senior, allowing the senior to have a better relationship with that caregiver or the family.
That's a great point. Great. Is there anything else that you'd like the viewers to know about PACE?
Some of the things that are included in PACE that are a lot of folks don't know about, and they're hot topics. Dental is covered 100%, including dentures. Optometry, including eyewear. Acupuncture, chiropractic, medications, transportation to and from our adult day health site in the person's home, and all medical appointments.
Wow.
We book it all for them to make the ease, to make sure that we get the paperwork, that we coordinate all of the details. And this includes a homemaker at home. We work with a person at their home as much as we work with them at our adult day health site. And the beauty is, if a person wants to come in once or twice a month, that's what we'll do. But if a person becomes more frail and really needs a higher level of supervision, we're going to encourage that person to come in perhaps 5 days a week.
Really?
But we're also caring for them when they're not at our day site. We're caring for them 24/7. We have a nurse on call, nurse practitioner, and a doctor, and they are just as apt to make a house call on the weekends or nights.
Oh, okay, great. And the day site, just to be clear, is you come in and you meet with multiple care providers for your appointments. It's not adult day care.
No, it is not.
Okay.
Very good point. It's I like to say that it's a combination between like a Harvard Vanguard, where I go to, combined with YMCA for seniors.
On that note, Michelle, thank you for joining us today.
Thank you for having me.
We just heard from Michelle of Elder Service Plan of the North Shore. And now we're going to switch gears a little bit, and we have Suzanne from North Shore Elder Services.
Yes.
So similar name, but quite different programs.
Correct.
Okay. So can you tell us what Elder Services does and how it differs from PACE?
Absolutely. North Shore Elder Services is what's known in the state as an Aging Service Access Point, or if you're in my world, you just call us an ASAP. There are 27 of us throughout the state, and we are designed to be one-stop shopping for elders in the community. Our services range from intake and referral, home care services, Meals on Wheels, a lot of other things that we provide for elders within the community. We're partly funded by state money, partly by federal money. The money is all funneled through the stop. I'll just take it from
the money.
The money is funneled through the Executive Office of Elder Affairs. And each agency is funded to provide services for elders within their service community. Our service community is Salem, Peabody, Marblehead, Middleton, and Danvers. And so we provide a whole realm of services. Our intent is to provide service from beginning to need care all the way through much more chronic and disabling disease.
Okay. So if I'm hearing you correctly, do you then outsource to specific care service providers, and people can pick and choose what they want to take advantage of?
Yes, to become a client of North Shore Elder Services, you have to meet a few thresholds that the state mandates.
Okay.
One is that people have to be age eligible,
Okay.
which means they have to be 60 years of age or older.
Okay.
An exception to that is, however, if you've been diagnosed with Alzheimer's disease or a related disorder, you can be eligible for services at a younger age.
Okay.
So you have to be age eligible, you have to be frailty eligible, which is assessed with an assessment tool that the state provides to us to assess people's frailty level. And you also have to be income eligible. The design of the program is not to provide service for all people, it's to provide service for folks who meet certain guidelines in terms of not poverty level, but certainly the services aren't intended for people with enhanced means of their own.
Okay.
And so when we get a referral, it can either be from a hospital, a nursing home, a VNA, a family member, a friend, or the elder themselves. And so in our intake and referral department, there's an assessment that's temporarily made over the phone to see if it sounds as though people will meet criteria. And then a referral is made to our home care department, and an intake case manager goes out to meet with the elder and whomever they would like to be at that meeting in their own home to assess whether or not the services might be able to be of help to them.
So how would your services differ than than what's provided by the VNA?
Good question. The VNA is in an elder's home under doctor's orders. They are the immediate response after a hospitalization or a nursing home discharge. The interval between the elder coming home and being seen by the VNA is often very, very short. They provide skilled care. They're providing care under a doctor's order.
Okay.
We are not providing skilled care. And we don't necessarily go out immediately after discharge. We don't have people sort of standing by at the ready to go out in a moment's notice. I wish we could, but we can't. So we go out there in a very reasonable time frame, but our services are not meant to be emergency relief or medical for people who are, medically in need of skilled care.
So a person wouldn't need a referral from their doctor,
No,
or they
correct.
don't need to join or anything
Correct.
like that. They would just call you as services might be needed.
Correct,
And you'd
exactly.
identify what type of services they might be eligible
Yes,
for.
that happens in the in-home assessment.
Okay.
There's a discussion of what services are needed, what is the elder willing to accept. Oftentimes we'll run into situations where families think that Myrtle really needs a lot of help, and Myrtle has very different ideas. So there's usually some negotiation that goes on.
Yes.
Our favorite referrals are when the elder's daughter refers mom or dad or whomever for service, and we go out to assess for service, and the elder will look at the assessment team and say, "Oh no, I don't need help with that. My daughter does it." So there's a lot of give and take in the process.
So do you provide support to the caregiver as well?
We certainly try to. We have a whole complement of service that we can provide to caregivers, either through the Family Caregiver Program or through an options counselor. Because I think oftentimes the caregivers are the ones that feel the stress the most. Or I shouldn't say the most, but the earliest.
Sure. Now, are these services covered by insurance? You mentioned that there were income guidelines and you're funded partly by the government.
We do not accept insurance.
Okay.
We have some of our clients who become eligible for Mass Health, and so they can be eligible for a much richer package of service, but there's a process to go through to become eligible for that. An initial client just walking in the door is not usually covered by Medicare or Medicaid. The money gets funneled through the Office of Elder Affairs, but it's not billed to their insurance. And in fact, for many of our clients, there is a copay for our service, which is based on income. It's a sliding scale based on income. So that's a big difference between our service and VNA. For VNA, there's no copay required, and so a lot of elders assume that all services for them will be without any copay, and unfortunately, the state assumes that we're going to be collecting. It's not an exorbitant copay. It ranges from $0 to, I think the top level right now is $155 a month for service. It's not an hourly rate. And we contract with vendors who provide the service.
So would that be a fee per service? So if I had
No.
Meals on Wheels and then I had a home health care aid, or
No, that would all be part of the
Oh,
service
okay.
plan. So no, it's a monthly rate for all services included
that
in a
whatever
service
you
plan.
need?
Yes,
Oh, all right.
yes.
So that's actually very reasonable.
It is, particularly if the service plan gets very, very rich, it can cover a lot of care.
And then as somebody takes on more and more services at some point, is there somebody who's overlooking to see what the situation is at home and
Absolutely.
whether or not they need to move on to a different step?
Yes, absolutely. There's a mandate by the state that elders in basic home care be seen at least twice a year in their homes to assess for service and to assess how they're doing. There's also frequent phone calls. And as they get into more advanced levels of care with us, the mandate is for in-home visits at least 4 times a year. And the highest level of care, the expectation is the elder will be seen at least every other month, and frequently more often, because we have a pattern of going out to assess people. If they've had a lot of hospitalizations, we'll go into the home and see how they're doing and what's different. To us, a hospitalization is a red flag that something needs to be looked at. And so there's a lot of give and take and a lot of attempts to look at what services are needed at this point if something's different and things need to change.
So do you have like some sort of central coordination point that if somebody's receiving multiple service from different service providers, that it all kind of gets funneled back into like one case file, if you will, so you see the whole picture?
It gets funneled through one case manager and frequently a nurse who's also attached to the case.
Oh, okay.
And those folks are, they meet frequently to talk about how the elder is doing, to discuss whether additional services are needed, to see if we need to look at referring them to a more rich service plan in a different program that's still part of home care, but it's just it's funded in a more diverse, in a more robust way.
Right. Now, you hit on something a little bit earlier when you said that sometimes the caregiver calls and is starting to request some assistance, but the person who needs it is saying, oh no, I'm fine. How do you mediate a situation like that? Because I think that's a fairly common occurrence. And
we often will find that it happens more frequently if we're just meeting with the elder alone, which of course we will do, but we often encourage, if the caregiver made the referral, we'll ask at the point of setting up the appointment if they'll be able to be with the elder at the appointment. And our intake case managers are pretty good at turning to whoever the provider, the caregiver is, and saying, gee, I'm saying it this way, is that how you feel as well? Sometimes it can get a little interesting, but oftentimes the elder will not necessarily be aware of how stressed the caregiver is. And so at that point, it can be a discussion between the two of them about, maybe it is time to allow somebody to come in.
Right.
A lot of elders were born in a time where, they didn't have help in the home. It's a very different phenomenon for them. And some of them, it makes them very uncomfortable to have strangers come in, which is totally understandable.
right.
But they may be at a point where it's time, and oftentimes once that bridge is sort of gone over, it helps with everybody managing better.
Well, I think too that the first time especially, that you're put in a situation to care, for a loved one like that, you don't know where to go either. So I think it's great that there's a resource like this available. So is there anything else that we haven't talked about that you'd like our viewers to know?
Nothing's screaming out at me. We're in a situation these days where no one's getting younger. Everyone ultimately becomes aware of the service that we have. I used to joke with people when I first started working for North Shore Elders, which is about 15 years ago, that learning the elder health care system, learning the elder health system is a lot like when you have a child and you're learning the child care system, because you don't really understand how it functions until you need it. And we're finding more and more that when people do sort of become aware of the services that are available, they're greatly relieved and can really benefit from the assistance. At least that's our hope.
Yeah, no, it sounds that. It sounds like it's a fabulous program. So thank you for joining us today. So there's Elder Service Plan of the North Shore and North Shore Elder Services, both which provide home care through government programs. Now we're here with Pam from BAYADA. Pam, how does private home care work?
So private home care is so great because it helps people stay where they want to be, which is at home. Those programs somebody might not be eligible for, or even if they do have elder services or PACE, they might want some additional or need some additional services, and that's where we come in. With private home care, it's those activities of daily living. It's called personal care or assistive care. So you might need help with bathing, grooming, dressing, or homemaking services. So that light housekeeping, doing the grocery shopping, picking up prescriptions, or, I mean, we can get really creative. That's the nice thing about private care. If you love playing checkers and you don't have somebody to play checkers, we can send a homemaker in to play checkers with you once a week. So we had a client one time who loved going to the movies, and we would take him to the movies once a week. So you can get really creative with private care because there are no restrictions on what you have. It's whatever you really choose to have. So the process with private home care, we have a clinical manager who will come out and meet with you and anybody else who's been involved in the care. So if you have adult children who've been doing that caregiving activities, they'll be there to talk about what have they been doing, what's worked, what do they need extra help doing, what isn't working. And the clinical manager, an RN, she'll do a full assessment, make her recommendation about how many hours do you think they need, and then she'll do a personally designed care plan specifically for that client that our home health aides will go in and follow every time they have a visit. So the clinical manager, she comes out after services are set up once a month, and every 6 months she'll do another full assessment. But she has those eyes on the client every single month to make sure if there are any changes, if we need to do any updates, if hours need to be increased, you're going to be safe at home because you have a nurse, not just a homemaker or a home health aide. You have that nurse looking after you.
And is it the same person who typically goes to the house week after week or day after day, however many hours it is?
We really love to have consistency of care. So we try to have as few aides on a case as possible. Even if it's only 2 hours a week, I still like to have at least 2 aides introduced to the case.
Right.
Because when life happens, there might be a sick child or whatever it may be, and we don't want you to be in a position where you don't know who's coming into your home that day. So at least 2 people I try to have on every case, and then that way they can cover for each other and you have consistency. You know who's coming in your home. They know your care plan. They know your likes and dislikes. They know where the dishes go. So it makes it a lot easier.
Right. And what kind of costs are associated with, trying to obtain these services?
So Julie Lowe, our elder law attorney here today, she's going to talk a little bit more about long-term care insurance and VA benefits, and we already had the ASAP and the PACE program talk about those government programs. So what it really boils down to is if you have long-term care, which is kind of like your life insurance, so you had to purchase it ahead of time. We work directly with the long-term care, which is really nice. Not every agency can do that.
Okay.
So we have a whole office dedicated to doing insurance confirmations, finding out what your benefit is, finding out if there's an elimination period so that we can come up with an alternate plan for that elimination period, and billing directly, which is huge because it can get expensive, and a lot of agencies require that you pay up front and you deal with your long-term care to get that reimbursement. And so we deal with the reimbursement on our end, and it makes it a lot easier for the clients to not have to worry about that piece. But if you don't have long-term care and you don't have one of those programs, or you do and you need additional, it comes down to private pay. And that's one of those things you're going to want to talk to your agency. If you're talking to a few agencies that you're looking at having come in and do your services, find out what their costs are, because it does vary. but you also get what you pay for. So you want to make sure what services do they have behind those costs. BAYADA breaks it down. We really try to make the most cost-effective plan possible. So we have different rates for homemaking, which is no hands-on, versus home health aid, which is those hands-on. If you need help with your shower, if you need help with your grooming, then it's going to be a little bit of a higher rate. And we also break it down by hours. So if you're having 1 hour of service, it's going to be a higher rate than if you have an 8-hour shift of services. So we can really make it affordable. There's also transportation costs. So if you need a ride to your doctor's appointment, or if we're doing your grocery shopping for you, there is a charge for that as well. And again, it varies agency to agency, but for homemaking, it's going to be, around $19 to $22 an hour. And for home health aid, it's going to be anywhere from 24 to, I've heard, 35 at the high end for a 1 hour service. But again, BAYADA really works with you on putting together an affordable plan. That's that key piece with having our clinical manager come out. There's no charge for her ever. And she'll talk to you about what hours and how can we make this the most affordable plan, because our goal is to have you be home and have you stay home as long as possible. So if we can make it more affordable to keep you there longer, we will.
Sure. Now, you mentioned, I caught that you were talking about transportation and being able to drive somebody to a doctor's appointment, or is it just doctor's appointments, or if they needed a ride maybe to go visit a friend, can you do that as well?
Absolutely, anywhere they want to go. Sometimes we'll give people rides to daycare because they can't make it when the bus is scheduled to go. So we'll give them a ride there, hair appointments. If they want to just do some shopping, bring them downtown to the shops. It's really, that's the great thing about private pay is it's your dollar, so wherever you want us to take you, we'll go. And one of the nice things with the doctor appointments is a lot of times the adult children aren't nearby. So you might forget when you're sitting in that doctor's appointment, what did they say when you want to go tell your daughter? And so the home health aide can be there and then have kind of a case conference with the clinical manager and the children in the family who are taking care of mom or dad, and talk about what was said in that appointment.
That's actually very convenient. And so unlike, I know a lot of probably seniors take advantage of the ride, where they have to call up and make an appointment in advance and maybe share the ride with somebody else. This would be just for themselves, the ride to and from.
Yeah, and it's nice because they have that home health aide to help them if they have any issues, they're using their walker. We're right there to help them along.
Wow, that's excellent. So what are some of the questions you should ask when you're looking at home care providers?
So if you're interviewing providers and you're trying to find who's going to be the best provider and who's going to, don't just go with what's most affordable, because like I said, you really do get what you pay for, and so you want to make sure you're getting all the services that you're really entitled to. So I always say cost is going to be a factor, but also look at, are they accredited? People always know that their facilities, those skilled nursing facilities and rehabs, they're accredited. They're under usually JCAHO, but home care, it's not a requirement, it's a choice, and it's a hard choice because it's a really high standard. You're held to really high standards if you're accredited. So BAYADA is CHAP accredited. It's the Community Health Accreditation Program, and it's specifically geared for community health, so those home care agencies. And they come in, they do an audit. We have high standards, so we audit ourselves once a quarter. We have our nursing department come down and do that, but it's a mirror of what CHAP does. So accreditation is huge. The other thing is clinical oversight. Do they have a nurse? A lot of smaller agencies don't have a nurse who's overseeing that care. So you want to know, do they have a nurse? How often is that nurse coming? Do they charge for that nurse to come? We go out there every single month, no charge, and that's kind of unheard of. So check that. You also want to know, what are their hiring standards? So do they hire anybody right out of getting their certificate, or do they have 1 year of experience required like BAYADA does? Are they doing background checks? How many references do they check? Do they test them? Do they test skills? What's their orientation process? Those are things you're going to want to know because they're going to help you gauge what kind of quality employer you're getting.
Sure, and as we were talking earlier with some of the other guests, it's, elders are often reluctant to let a stranger come into their home, so that must give them some level of insurance too, that people have been checked out, they have had background checks, and they're not going to walk off with the family jewels or something like that. Yeah, that's great. So why should someone choose an agency over hiring a home health aide directly?
So the biggest reason, it's security. Like you just said, they're not going to walk out with the family jewels. We're insured. So if you hire someone under the table, again, it's going to save you a few dollars, but it could cost you so much in the long run. So it's not just protecting your valuables, it's protecting that employee because you're their employer. And if they were to get injured at work, who's responsible? You could face a huge lawsuit. So it can be really scary. And if you hire an agency, I mean, that's part of what they're dealing with is put that burden on them. Security of knowing that your aides are qualified and followed up on, and having that clinical oversight, knowing that there's a nurse who's checking in. Are there any changes? Little things like a UTI could go unnoticed if you don't have a nurse in there.
Right. I know, I didn't realize. So can really anybody just kind of hang out a shingle and say, I'm a home health aide?
In Massachusetts, unfortunately, they can. It's very limited on what the restrictions are.
Huh, that's kind of scary.
It is.
Wow, that's great. Excellent. Is there anything else about BAYADA that you'd like the viewers to know?
Not really about BAYADA, but home care in general. My biggest thing is I understand how hard it is to accept somebody into your home. And what we always tell people is the hardest step is the first step.
Right.
But once you meet that aide, you're going to bond and you're going to look so forward to having them in your home. It's going to be your treat for the week. So just be open to the process. BAYADA has, no contract, no minimum. You can try us for a day and say, you know what, I don't like it, but you're gonna love it. It's just being open to the experience, and it's something that you need to do to take care of yourself.
So, again, the whole idea of today's show is to make sure that people can stay in their home for as long as possible. So they could start off with some minimal services. They need some light housekeeping done. They can't wash the kitchen floor or scrub the bathtub, that type of thing. You can
And then we have that nurse, when she notices there might be a change, she'll make a recommendation. I think you might need some help with the showers now, and we can add that right in.
Wow, that's great. Well, thank you for joining us.
Thank you for having me.
Now let's hear from Julie Lowe, attorney at law. Julie, what's the difference between Medicaid and Medicare, and who's eligible?
That's a great question. Medicare and Medicaid sound alike. They're almost the same word, so they're easily confused. Not only that, they're both government health programs that help pay for health care.
Okay.
They were both created in 1965, but that's where the similarities end. That's beyond that, they're completely different. So, for example, who runs the program is different. So the federal government runs the Medicare program. So there are consistent rules and regulations across the states, whereas Medicaid is a jointly funded state and federal program. And so every state has different rules for Medicaid.
I had no idea.
Yeah, so it's important if you're looking at Medicaid eligibility to be sure you're speaking to an attorney who's licensed in that particular state and knows that particular state's rules.
Okay. So could somebody in a case be eligible for both Medicaid and Medicare?
Oh,
Or-
absolutely.
Oh, all right.
We refer to those as dual eligibles. And yeah. So another difference is how someone applies. Medicare, you apply when you apply for Social Security, and you're automatically eligible when you turn 65. And whereas Medicaid is applied through the state Medicaid agency, which in Massachusetts is Mass Health. So Mass Health equals Medicaid in Massachusetts. Another difference is what do they cover? So Medicare covers typical everyday services such as doctor visits, inpatient hospital stays. It also can cover prescription drug plans if you have a Part D plan. Whereas Medicaid is more focused on covering long-term care, be it in the community or within a nursing home.
Okay.
Either way. In addition, one program is needs-based and the other is not. Medicare, Bill Gates is eligible for Medicare. Okay, there's no income or eligibility requirement. Bill Gates would probably never be eligible for Medicaid because that is a program specifically based on need, and it's for individuals with lower income and resources.
Okay. So what is the role an elder law attorney plays in keeping somebody in their home as they age?
Well, an elder law attorney can play a very key role in keeping somebody home as they age. We are uniquely qualified in understanding the rules of the various community options that are available. For instance, in Massachusetts, there are 11 community programs that I can think of kind of right off the top of my head. Community Choices, Personal Care Attendant Program, Group Adult Foster Care, the PACE program, which you heard from earlier, fabulous program, Adult Foster Care, Enhanced Community Options Program. There are so many, each program has a different set of requirements and rules attached to it. So it can be difficult to navigate the rules of that, of all those different programs. And quite honestly, when someone's facing this situation, they're facing it for the very first time. Whereas elder law attorneys and other professionals see these situations on a regular basis. So they can help you navigate the rules much better than you that are facing it for the first time. And so not only does an elder law attorney know the rules and regulations of the various programs, we also can help you legally reposition your assets to become eligible. Sometimes not even a lot of legal repositioning of your assets. So for instance, there is a home and community-based waiver program in Massachusetts that enables a client of mine to have a much higher income than is traditionally allowed under the Medicaid program. And with that community-based waiver, they can then become eligible for other programs like the PACE program, which is a fabulous program and is designed to keep people in their homes. The PACE goal and the client's goal are one and the same. PACE goes to great lengths to keep people in their homes. I've seen them buy hospital beds for clients. I've seen them provide machines for diabetic neuropathy and fingertips. I've seen them provide a great level of service to keep people in their home. And I think one of the things that we've learned is that the government saves money when it cares for people in the home. In fact, a recent study in Massachusetts stated that the government spends 35% less on an individual when they care for them in the community than in a nursing home. And so for those reasons, the programs they have a little bit less stringent requirements because the government laxed them up a little bit so that they could get more people eligible for home care to prevent that nursing home care.
Well, nursing home has become almost cost prohibitive for most people, correct?
Oh, absolutely. And so one thing that whenever you're working as an elder law attorney and your practice focuses on that, you come across numerous professionals that you know, that you learn to trust, and you can make referrals, and you can then work collaboratively with a number of resources to provide a holistic approach to someone's care, not only financially and legally, but also care management-wise as well. One last thing I want to say about home health care and how an elder law attorney can really help with that. I happen to be an accredited attorney with the Veterans Administration, and there is a great program, and it's a little-known program. I find so many veterans that know nothing about this particular program. It's often referred to as aid in attendance. But it's a great program that gives them a cash benefit monthly, tax-free, that enables someone to pay for care at their setting of choice. So for instance, a married veteran can be eligible for up to a maximum of $2,054 a month. A single veteran can be eligible for up to $1,732 per month.
Wow.
And a widow of a veteran can be eligible for up to $1,113 per month. The key here to the VA benefits is to understand how to qualify for those benefits. And it's also really key that if you do veterans benefit planning, that you also understand the interaction with the Medicaid eligibility rules. Because you can do veterans planning that actually renders you ineligible for Medicaid for the rest of your life. So I encourage any veteran who's seeking out elder law attorney services to make sure their attorney understands both the veterans benefits and the Medicaid rules and how they contradict and how they can work together so that they can always keep their eye on the other ball while planning for the better of the two benefits in any particular situation.
Wow, that's good to know. There's also another thing called an advance directive. What would that be?
So an advance directive is a legal document, sometimes often referred to as a living will.
Okay.
And so that talks about end-of-life care wishes. What kind of care do you want to receive? It basically provides instructions for the kind of care you want to receive. It's important to note that it's way more than a DNR.
Okay.
I hear clients say, well, I have a DNR, a do not resuscitate order. And an advance directive is much more than that. It can cover things such as additional medical procedures, artificial nutrition and hydration, and also it can be aimed at diagnostic procedures that are not aimed at curing the underlying condition. Many people don't want to go through diagnostic procedures that might be otherwise painful or uncomfortable when it's not aimed at curing the underlying condition towards the end of their lives. And sometimes when I think of the advance directive, if anyone remembers the Terry Schiavo case in Florida, advance directives and living wills became famous through that case.
Right.
So advance directive, think Terry Schiavo.
So what's the, you throw around a bunch of words here. So what's the difference between having a healthcare proxy and a medical power of attorney?
Oh, well, a healthcare proxy is considered a medical power of attorney. But there's also a durable power of attorney.
Okay.
So there are very big differences between a healthcare proxy and a power of attorney. The main difference is that a healthcare proxy in Massachusetts is designating an individual and alternates to make your healthcare decisions for you, whereas a power of attorney is designating an individual to handle your financial and administrative affairs in the event you, due to an illness or incapacity, you are unable to do those things yourself. So another major difference between the two documents is that a healthcare proxy is invoked if and only if a physician certifies that you're unable to make your own healthcare decisions. It's not effective immediately upon signing. Your healthcare decisions are not going to be, you're still making them. It's okay.
I think that's a very big fear among the elder community, is that they're giving power to somebody else.
Absolutely. And usually the power of attorney is effective immediately upon signing. You know, at least that's what I recommend to my clients.
Okay.
Why? Because this document is intended to prevent the need to go to court to get a conservatorship or a guardianship for an individual. Now, if you state in your power of attorney that, well, this is only effective when I'm incapacitated, and you take it to the bank, they're going to say, well, prove you're incapacitated. Well, then you're back in court. And you're spending tens of thousands of dollars in legal fees, often. This is the document that's fairly inexpensive that everyone should have put in place. And it should be, if someone says to me, I don't really want to make it effective immediately, and I'll ask them, well, why? You don't. If it's because you don't trust that person, then we should be having a different discussion.
Okay.
That shouldn't be the person that you're naming in the first place. If you don't trust them now, you probably aren't going to trust them later either. So we usually
That's
have
a very good point. I like
we have
that.
a different discussion, you know, about that. And you know, I have to say that these documents are my pet peeves. Okay, the healthcare documents, which I refer to as a living will and a healthcare proxy and a HIPAA authorization, as well as the power of attorney, are documents that I think everyone over the age of 18 should have, but especially as you are aging and needing long-term care. It's crucial to have those documents in place while you still have the capacity to sign those documents.
Right.
Once you've gone too far and you don't understand what you're signing, we really can't do one. Okay, so it's really, really important. And more importantly, they need to have specific provisions, and they have to enumerate specific authorities and powers. For instance, I often see the healthcare proxy form from the hospitals. It's a one-page form that simply designates an individual. And if you don't have any other healthcare proxy and you're facing a medical procedure, you should absolutely sign that, because it's certainly better than not having one at all.
Right.
But you should go beyond that. You should list things. You should give someone instructions. Okay, you're asking someone to make some really important decisions, your healthcare decisions. You know, and they're difficult decisions because you're usually giving it to a loved one when they're emotional and maybe not thinking clearly. So I think you ought to give them some instructions and a little bit of guidance other than just naming them on a form. So, for example, you should express your intention to remain at home while giving your healthcare agent the authority to place you in a safe setting. You should also give your healthcare agent the ability to apply for government benefits on your behalf. There's things that should be specifically enumerated in these documents. You know, healthcare proxies are intended for real-life difficult situations. And when they have to be used, it's never easy. You want to make sure the person that you've designated understands your wishes. You can do so through the document. You should also have a conversation with those individuals. I think these documents are only as good as the conversations that people have around them. And when you really think about it, it's also, again, when a loved one is facing a really difficult time, perhaps, you know, the pulling of the plug decision, oftentimes,
Right.
is a very difficult one, and a family member might have a lot of guilt around that. So having a discussion and giving them clear authority and stating your wishes about when and why you want that plug pulled is really important. It's really, the people I've talked to who've had to make those decisions were really glad that they had instructions.
Right, right, I can imagine.
Surrounding that. And likewise, the power of attorney document for financial affairs. You know, I see the standard form power of attorney. You can pull one down off the internet. This is another one of my pet peeves, because as you age, there are things that you should expressly authorize the person that you name to handle your financial and administrative affairs to do. For instance, you want to authorize them to do estate planning and or Medicaid planning. Okay, you want to give them the ability to gift your assets. You want to give them the ability to update beneficiary designations on life insurance policies and retirement plans. You want them to be able to handle your mail and your taxes. You want them to be able to take care of your pets. I mean, in my power of attorney document, I expressly authorize very specific provisions, because the courts in Massachusetts have spoken, and what they have said is that if a power of attorney's actions come into question and it was an action taken that wasn't specifically enumerated in the document, they lose every time.
Wow.
They've lost. Medicaid decisions and appeals have turned on the power of attorney document. So it's not just simply a pet peeve.
Right.
In real life and in a difficult situation when an action is being challenged, it's really important to give express authorization for very specific things. So that general statement in a power of attorney that they can do whatever I can do,
Right.
I think is insufficient. Necessary, but also to add to its specific powers.
Wow.
Should be in there.
Incredible.
Mine has a table of contents, if that gives you any idea. So,
Well, it sounds very comprehensive and good both for the person it's protecting and the person who has to make the decisions, it sounds like.
and that's who I'm writing it for.
Yeah.
I'm not writing it for the institution who has to read it.
We talked earlier about long-term care insurance, something that is a relatively new product in the marketplace, probably last 5-10 years? You hear more about
Yeah.
it lately, but I think it's become more and more of a need for most people.
Oh, yeah, absolutely. And so long-term care insurance, first of all, if you want to purchase long-term care insurance, you should definitely seek out an insurance professional that's uniquely qualified and knowledgeable about this particular insurance product. It's unlike other insurance products. So what does it cover? Long-term care insurance is designed to cover custodial long-term care services, those services required due to chronic illnesses or a condition that's lasting a prolonged period of time. If you remember from the earlier discussion we had about Medicare versus Medicaid, Medicare does not cover long-term care services. No one should rely on Medicare for long-term care services. That would be a mistake. So long-term care insurance can fill the gap and provide custodial care when it's required, or when skilled nursing care is required beyond what Medicare will cover.
Now, but is there a situation where you could be on Medicaid and also have long-term care?
Yep, absolutely.
Okay.
Oh, absolutely. I have a client right now who's receiving veterans benefits and using his long-term care insurance policy to finance a stay in a fairly expensive yet very nice memory care unit at a local assisted living facility. You know, the costs there are running between $9,500 and $10,000 a month.
Wow.
There's very few people, and that's for a memory care unit in assisted living. So it's pretty high-end care, and he needs the highest level of physical care as well as the memory care. So, you know, so it's very expensive, and very few people have the means to
Sure.
pay for that kind of care on any kind of long-term basis. And so there's three basic types of long-term care policies. There's nursing home only that may also cover assisted living facilities as well. There's home health care only policies, and then there's comprehensive policies that will cover the whole range of services from home care through assisted living and all the way into nursing home. The typical policy is structured normally as a daily benefit rate.
Okay.
It'll say, oh, we have a maximum daily benefit rate of $125 for particular service. Okay, maybe higher for a nursing home and lower for a home care. They may say you get 80% of the benefit for home care. And then it's also usually given a maximum benefit period. So if you have a 2-year policy that provides 2 years of care, that would be 730 days of care.
Okay.
And then they would times that by the daily benefit rate to come up with your maximum benefit. So you can have a policy that, for instance, covers $125 a day for 730 days over the course of your lifetime.
Okay.
Okay. Now, another important thing about, and I heard it mentioned earlier, is the elimination period. There are little nuances around that in a policy, and you should read it carefully. The elimination period can differ from policy to policy and can make a huge difference in when the benefits kick in, how they kick in, and are they maintained, or do you have breaks in coverage and then have to start a new elimination period? Is it a lifetime elimination period? There are things like that that should be looked at. And so there's also, within Medicaid, there's a special rule and regulation.
Of course, there's a special rule.
There always is a special rule or the exception, right? And so long-term care insurance, if you purchase a particular type of policy that meets certain minimum requirements, you can actually be exempt from Medicaid estate recovery and liens, which is the process by which, if you are on Medicaid during your lifetime, the state of Massachusetts will attempt to recover against your estate after your lifetime.
Okay.
And that's done through the probate process, and there are ways to avoid that, but other ways to avoid that, but one way is to have the right kind of long-term care insurance policy. If you buy a policy, though, for this particular reason, you should have it reviewed by an elder law attorney or someone else who really knows exactly how the rule is
To make
played
sure
out.
if you're looking for that coverage, you're getting it.
And played out in real life. I mean, there was an interpretation of the policy until recently the legislature updated it because it was being interpreted in a strange way and not in the benefit of the client or patient. And really, it was a measure by our legislature to encourage people to buy these policies to reduce their dependence upon state and federal benefits. And so that's what it should do. And, and there was an interesting information I came across. The National Association of Insurance Commissioners actually established some suitability rules for long-term care insurance. In the Northeast, or anywhere actually, they recommend that no more than 7% of your income should be spent on long-term care insurance. Bottom line is, if you're purchasing long-term care insurance, it should not change your lifestyle significantly to pay the premiums.
Right.
Okay? And one last thing is, if you buy a policy, before you sign on the dotted line, it might be a good idea to have an elder law attorney review it. Because they may see some nuances in those policies that you may not notice or even realize the consequences of
Right.
it. Even if you understand what it's saying, it may be hard to imagine the consequences as you're signing that policy of what that sentence really will mean to you down the road.
Well, and I can imagine, too, that not only does the long-term care insurance provide some peace of mind that you can pay for the care that you need when you need it, but it also is protecting your assets as well, for if you want to bequeath them to somebody later on.
Oh,
Correct?
absolutely.
Yeah. So
Absolutely,
it's
yeah.
kind of a double-edged.
Yeah.
That's great. Wow. Lot to consider.
There is a lot to consider. Yeah.
Well, thank you for joining us today.
Well, thank you very much for having me. I appreciate the opportunity.
Now we're going to hear from Mary Crow from Hospice of the North Shore in Greater Boston on the role hospice and palliative care plays in keeping elders home safely. Mary, tell me about the Hospice of the North Shore, its mission, and its services.
Yes, Hospice of the North Shore in Greater Boston is the largest not-for-profit hospice in the state of Massachusetts. For over 35 years now, our mission has been to enrich quality of life for people, and that's through expert care, support, education, consultation for people that are facing life-limiting illness, death, and loss. We cover over 90 communities in the state of Massachusetts, and that includes the North Shore, Greater Boston, Metro West, Merrimack Valley. We provide care anywhere the person calls home, and that can include their own personal home. It can be in assisted living, long-term care facilities, in hospital settings, and a variety of other settings as well, including an inpatient hospice facility. We have the Kaplan Family Hospice House, which is the first licensed inpatient hospice facility in the state of Massachusetts. So it was so new at the time, actually being the first licensed facility, that Hospice of the North Shore in Greater Boston was instrumental in terms of developing those new, the designation, the licensor designation during that time. So that was in 2005 that opened, and it is, again, a licensed inpatient facility. And it's in the Danvers area, and it's in a beautiful residential area of Danvers, surrounded by marshland, and it is very much set up for a home-like setting. And it has private suites. It's surrounded by garden areas. It has living room areas for the families, a country kitchen, and so again, it's just very welcoming and inviting. In 2010, it actually, because of the need, it was expanded. Initially, there were 12 suites, 12 private suites, and then in 2010, because of the need, it was expanded to 20 private suites. Wow. So it's just been a wonderful resource.
Now, is that something that somebody can call up and say, I'm in need of the service, or are you referred there by a doctor or a hospital?
Yes, with the inpatient license facility, you actually need to meet inpatient criteria.
Okay.
So generally, again, we would go out and evaluate to see if that person is meeting that criteria. And what that means is that are people's pain or symptom issues needing to be aggressively managed so that they require inpatient stay.
Okay.
So people might call up to have us evaluated either through the hospital or personally to be evaluated for that inpatient stay. We might get a call from the physician, or they might already be on service under the routine level of care. And again, our staff would indicate that they are in that inpatient setting and might benefit from being into the house.
So just from my understanding, because I'm not that familiar with this area, I guess under what circumstances would somebody actually have to be, if they're that ill, leave the hospital then to take care of these services?
Yeah.
What's the defining factor there?
Well, again, people hopefully will have a choice in where they want to be at end of life. So most people don't want to be in a hospital setting. So again, they could be at home, and if people want to stay at home, sometimes people will go to the Kaplan Family Hospice House even to have their pain or symptom issues managed and then return back to their home setting. So it doesn't mean that everybody going to the Kaplan Family Hospice House is going to die there.
Okay.
Most people do, but not everyone. And again, those pain and symptom issues can be managed, and then they can return to wherever they call home. And that goes for assisted living and skilled nursing facility or long-term care facility as well. So hospital settings, some of them they do. They have hospice beds there. They're smaller in number now. And again, part of that is by having these inpatient hospice facilities. But again, it would be their choice about where they would like to be at end of life.
And who pays for that type of service?
Okay. So for general inpatient level of care, there's 4 levels of hospice care. Routine being the general level of hospice care. So people who qualify for a routine level of hospice care, those people, again, they need to have a life-limiting or terminal illness. And the prognosis...
Excuse me, as defined by their doctor or their primary caregiver? Or?
Yes. These are conditions, Medicare conditions of participation, so a life-limiting illness or terminal diagnosis. Now, that's by 2 physicians, their primary care physician and also the medical director of hospice. So you have 2 physicians actually saying that they feel that person, given their diagnosis, that illness, and the normal or expected course of that disease, would it be a surprise to them if they did not live beyond that 6-month period of time?
Okay.
So those 2 physicians are attesting to that. So again, it doesn't mean necessarily that if somebody lived beyond that 6-month period of time that they're not hospice appropriate, because they absolutely could be. So again, so with that general routine care, in terms of coverage for that, most insurances have a hospice benefit.
Okay.
Now, under the hospice benefit, again, generally what's being covered under that hospice benefit is, and when I say most insurances, again, that includes Medicare, standard Medicaid, private insurances, all of that.
Okay.
In the state of Massachusetts, it's a mandate that all insurances based out of Massachusetts must have a hospice benefit. They can vary in terms of scope and coverage, in
Okay.
terms of, the scope of the benefit. The most comprehensive is Medicare. Okay. So again, with that said, with that routine benefit, the basically what happens is that person, they're getting the interdisciplinary team visits, also durable medical equipment, and any medication that pertains to that terminal illness that brought them onto service, that's covered under the benefit. All right, and so in terms of the licensed inpatient, like we were talking about, again, basically for somebody to be on that level of care, their pain and symptom issues are not, again, they're not being well managed, that they need to have aggressive intervention in terms of the frequency of skilled nursing intervention and all of that. So that's the differentiation
Okay.
between that.
Okay.
So in terms of going to the Kaplan Family Hospice House, if somebody is under that general inpatient level of care, all of that is included in the cost and it's covered.
So typically, do you see maybe that somebody starts off at home with a certain level of care and an illness progresses, and then maybe they need something more aggressive?
Well, again, not necessarily, because some people think, again, that when somebody is dying, that it has to be complicated in some way, and it's not always the case. So people can die in a very uncomplicated fashion, and their pain can be very well managed. Sometimes for other people, again, when their pain or symptoms need more aggressive intervention, that's when they would require that licensed inpatient level of care. We really want people to be in whatever environment they want to be. We want to make sure that they die and have their end-of-life care wherever they call home. So again, the hospice care can be brought to them in the home setting, in the assisted living, which they consider home, in the long-term care facilities or wherever, even group homes and things like that.
Do you find that sometimes families are resistant to having hospice care?
Sometimes yes. There's a lot of myths and misconceptions out there about hospice care. So, they hear that H word, as we say, and people get scared because when they hear hospice care, they're fearful that that means that the person is imminently dying.
Right.
And that we're giving up hope. And those are really misconceptions, because it's not true at all. When I think of hospice care, I don't think about dying, I actually think about living. And really, that's what it's about, because hospice care really focuses in on quality of life, living every day till its fullest for whatever that person, whatever time they have left, and really adding to that. Dying is not just a medical event. It really has to do with the whole person, spirit, mind, and body. And if we don't address all of those issues for that individual, we're doing a disservice. So I really feel like for hospice care, it's up to us, because I've had people say to me, how about changing your name? Don't say hospice. I feel like let's not change our name. Let's explain to people, or again, help to demystify, or get rid of those stereotypes about hospice care. Hospice is a beautiful thing.
Right.
Hospice care is derived from hospitality. So again, the word itself is not what's concerning. So for people, really, it's about, let's get out there and educate them so that they don't have to be afraid of that, of the word or of the service.
Right.
And what we often hear is that once we're out there and we're educating people and really giving them the full picture of what hospice care is about, they say that we wish we had gone on sooner. And that's often what we hear.
Right. I've had several friends who have taken advantage of it, or have had the services and couldn't speak more highly about it. totally not what they were expecting.
Exactly.
You know, so.
So we have a responsibility to get out there and to do that education so that people fully understand
Right.
what it's about.
And what kind of, I think part of it too is, you know, what kind of bereavement support do you offer families?
Absolutely. So, you know, again, part of that Medicare benefit that we spoke about earlier is also bereavement services for 13 months after that person has died. So that is for the family. And when I say family, that doesn't necessarily mean blood relation. That is for that person's support network. Family is anybody who you loved and who cared for you and who was a part of your support network. So that 13-month follow-up, what that does is that gets people through that first year and that the anniversary date. Now, you know, people's bereavement needs differ. So you can have people that they might feel that they need time beyond that. There's no such thing as a normal period of grief. Grief is individualized. So some people might need beyond that 13-month period, and others might not need even, you know, up till that point. It really varies for the individual. So we wouldn't say after that 13 months, we're not here for you. We absolutely are. We have the Bertillon Center for Grief and Healing. And the wonderful thing about that is it's unique because it's the only freestanding Center for Grief and Healing in the state of Massachusetts. And being a not-for-profit, we do fundraising events that you probably have heard about through the years. We've been doing the walk for many, many years. We've had the regatta, and we do that. All of the money that comes from those events goes back into patient care. We offer, through the Bertillon Center, we offer free support groups. We have workshops. Most of the stuff that's offered there, we actually do have individual counseling as well, which so many sessions are at no cost, and then there's a sliding scale fee. But all of the workshops and the support groups, they're free.
Okay.
And the workshops are either at no cost or minimal cost. And those services are not just offered out to people who have been on hospice services,
Oh, I was just gonna
but
ask
to
that,
the
okay.
community.
Okay.
You know, so you know, there was a good portion of people that would just, again, didn't even utilize hospice services, that utilized the Bertillon Center for Grief and Healing.
Right, right. And where's that center located?
That is located on Liberty Street, 78 Liberty Street in Danvers.
Oh,
So
okay.
the same location where the Kaplan Family Hospice House is. It's in a different part of that building.
Excellent. And can you tell me who and how somebody can make a referral to hospice?
So in terms of making a referral, anybody can make a referral to hospice. They really can. So it could be the doctor, it could be the patient themselves, it could be a family member, anybody. You know, we'll have social workers or other healthcare workers calling referrals in, but it really could be anybody. So what will happen is we do need a doctor's order,
Okay.
you know, to provide care.
Okay.
So what happens is, and what we do is we'll take that referral and then we will call and get the doctor's order. So the person doesn't have to do that. We could do that for them and follow up with that. And then we would go in and we would have a nurse evaluate to see if they meet criteria. So, and if they meet criteria, they would come on to service.
Wow.
So,
Well, I think it's a service that not everybody probably can provide, but you know, it takes a special person to do it.
well, thank you so much.
But I think it's a service that families really, you know, can depend on at a very critical time.
Absolutely. Yeah, it's, you know, it's a very personal time in someone's life, you know, end of life issues. And again, it's, you know, for most people don't die suddenly. For most people, it's a process. And again, that is so critical that the care and the pain and symptoms are well managed at that time.
Right.
Because again, people have a right to have dignity and be pain-free at end of life. And how they die is so critical to how their family moves on from there and how their grief is expressed. So it's really critical. And again, you know, so that end of life care, we need to get out there, we need to educate, we need to provide that quality care. And again, like I said, most people, they really feel like it was something that they couldn't do without. You know, so it's, you know, and most people, another misconception is that people feel like people come on to service, and as I said earlier, they think they're going to die sooner. They've done extensive research on that, and actually people on hospice care lived longer. And the reasons behind that were that their pain and symptoms were well managed, and also that they got that extra TLC.
Right.
And between those factors, again, they lived, you know, really a couple of months longer than what was expected.
Wow.
So, and with quality of life and dignity.
Yeah, that's good to know.
So,
Well, thank you, Mary, for
thank you.
joining us
Thank you
today.
so much.
Very important service, I think, for people to be aware of,
Thank
not
you.
to be afraid of.
Thank you. Appreciate having
Thank you
me
so
here.
much. Well, this was quite an informative hour. We hope we've helped you understand the many facets and options of home care so that you can navigate your plan for you or your loved ones. But if our viewers have any questions that weren't covered, they can reach out to any one of our experts. And on your screen is contact information for each of the groups represented here today. Thank you.